Arun, I want to ask you, how long would you give initial treatment with vonoprazole?
So depends upon the condition what we are going to treat. So mainly we are going to tackle with various indications and know. One is your reflex esophagitis and non-erosive reflex, ulcers, gastric and duodenal ulcer, as well as expedited eradication. But mainly when you are going to do expedited eradication, we are going to give a high dose regimen for up to the 14 days of therapy. But maintenance always to be considered at least for 8 weeks of therapy to be considered when you are going to see a patient with severe erosive esophagitis. That's what being considered. So at least 8 weeks of therapy to be considered depends upon the maintenance rate for your doctors.
So precisely, as of now, there's something called as of now, we are looking at use of vonoprazole mainly in severe reflux esophagitis and in PPI resistant cases. We are looking at use of vonoprazole. Not that you cannot use in mild cases, or if you are just starting the treatment, you can definitely straight away start them on vonoprazole. But you are looking at 8 weeks of use. Predominantly, you will look at 8 weeks of use, which is what you look at it as a healing phase of many of these conditions, and then you go on to maintenance. It's very much similar to that of PPA, where you go on a standard dose or double dose and then wean off after 6 to 8 weeks time, like in PPIs. For 10 milligrams maintenance dose, we can give you up to 6 months. The trials are there, but we need more papers to validate all those things.
Will you add dopamine or prokinetic in the
Sir, as of now, prokinetics are not being major tried with your prokinetic, your PCAPs, because prokinetics can be added as an individual molecule, and there is no, usually we are going to use a PPI like your domperidone, etioprid, or interprid, so it will be in combinations. But right now, as of now, your vonoprazole is not coming in combination. And moreover, with prokinetics, you can try, and most of the molecules want to be trying with your aquaciamide. If you are going to use aquaciamide, there are some papers to recommend that you are going to use at a dose of 300 milligrams. But when you are going to use a prokinetics, not much of major data to document that.
But GR is very recurrent disease, so how do you tackle it for long term patients?
See, medications is only to support the therapy. Only diet, lifestyle modification, elevation of all the basic things, and look into all the precipitating factors to be taken into account. Only medication alone will not take you into the high level. Our primary indication to look for evidence of whether the patient is going for evidence of grade C or D, esophagitis, worsening of symptoms, any alarming events if the patient is progressing or not. All those pointers we need to look into that, sir.
In data on probiotics.
Probiotics is always recommended, so that's what for what condition you are going to use. For example, if you are going to use expedited medication, you can use a probiotic safely. Rhamnosus or GG or all those things you can try, sir. Rotary also in the market.
In test follower, is it individually effective or it is combined with some other drug as triple therapy?
No, sir. Always you need to combine the molecule with a triple drug regimen. You are not supposed to give 1% alone. You need to combine it.
Yeah, instead of PPA, use a vonoprazole, sir. That's all. You have to.
Other combination.
So if we have any data on that triple combination, including vonoprazole.
Yes, sir.
Yeah, that's what one of the slides was there, sir. We showed how superior is vonoprazole.
Combined with the triple therapy.
Not combined with triple. Vonoprazole is part of the triple therapy. Instead of PPI, the vonoprazole will be substituted. That's all. Without acid suppression, there is nothing called H. pylori eradication. That is the basis of H. pylori eradication. Acid suppression. Instead of using PPI, then you tend to use a vonoprazole.
How will you distinguish GERD and EERD?
Kaushik.
EERD has a letting go of inhalation, nasopharyngeal. All this, how will you distinguish? By giving vonoprazole, if it gets healed, probably we can exclude.
No. See, the first what you have to look is in GERD, you divide it as NERD, that is non-reflex disease, and one is a severe erosive disease. One is non-erosive, one is erosive disease. So what is non-erosive is you do an endoscopy. The patient have all symptoms of reflux like heartburn, regurgitation and everything, but when you do an endoscopy, there is no esophagitis. That is NERD. When you do an endoscopy and if there is erosions, then it's erosive disease. So vonoprazole is effective for both, but it is more effective for erosive GERD. So, and the one more question is extraesophageal symptoms. That means like cough, laryngitis, and asthma trigger, and other things. Definitely, that is a part of a reflex disease symptom. So definitely vonoprazan is effective.
Where on essence side?
Yeah, that is also part of an extra esophageal symptom. It will definitely, definitely it will be helpful. Yeah.
Sir, in all conditions, where all you find PPI being effective, and in extraesophageal syndromes, if acid is the cause of these extraesophageal syndromes, not necessarily many times you just get a volume reflux and you get into trouble. In such cases, you have to prevent the refluxate to reach the extraesophageal organ. So that you will have to find out some way or other how to do it. But if acid is the cause of the problem, in such conditions, where PPIs will definitely be effective. In those, wherever PPI is effective, vonoprazan will also be effective. In fact, it may be slightly superior.
More powerful.
So similarly, one more thing, when you use NSAIDs, you develop interstitial nephritis, and a lot of situations we put PPI along with an NSAID to suppress the acid secretion. Because you said that the vonoprazan is less incidence of interstitial nephritis. So when in a setting of when a patient is supposed to be on an NSAID, is it safer to put vonoprazan rather than a PPI?
Sir, when you look at interstitial nephritis, it is a bad luck to the patient. That's a bad luck to the patient, bad luck to the doctor.
Yeah,
We do not know who is going to develop interstitial
But
nephritis.
the
Anybody can develop interstitial nephritis. So it is not about this thing. But when you look at the incidence of interstitial nephritis, it's extremely rare. Even with PPI, is extremely rare.
Yeah, because
Okay.
I put a lot of patients and they are not.
And I have, strangely enough, when you have 5 ASA is the main mechanism of treatment. But I have had 3 or 4 patients with interstitial nephritis due to 5 ASA. So, I know it's a sin for a gastroenterologist to have an interstitial nephritis due to a vonoprazan or a PPI, which will definitely affect his morale. But when it happens, it will happen. You can't stop it from happening. I'll ask Dr. Kaushik, what is the role of vonoprazan in NERD, like just you discussed, and do we have any global approval?
So the NERD is a big problem now. A lot of patients come with a lot of GRD symptoms. When you put an endoscope, it is normal. So, however, PPIs is also very good for NERD patient, but because you need us to give some kind of acid blocker, so PCAPs are definitely have a role, especially they can be taken as SOS basis. So when you take on SOS basis because of rapid action, so it's
That's one of the, it's a very valid, important point. Like what Dr. Kaushik is pointing out is that taking drugs on a PRN basis, like, all of you are aware, patients can have GERD, patients want immediate relief. If you want immediate relief, you tend to give antacid. Antacid will work for some time and then you get a rebound acidity. Afterwards, the patient will get into trouble. So, you want to go for a superior drug, you will have to use PPA. But then you take PPA today and it's going to take care of the reflux after 3 days. What's the use? You want something that will work today, immediately. That's what it is. The vonoprazan, you take it now, it will work immediately now. That is the beauty of vonoprazan compared to PPA, which is what he's trying to point out. That
Case only once daily or twice daily?
So vonoprazan is always once daily. So the initiation dose will be 20 mg and then the maintenance dose will be 10 mg. OD.
Twice daily.
No sir, it's once daily. Once daily.
twice a day is only in HP eradication, sir.
Yes.
As of now, the licensed this thing is only once a day for the treatment is once a day.
No conditions
Shall
except
we split it with the morning 10 and so the patient taking 20 milligram?
The beauty of this drug is the longer action. So it is 24 hours action. So there's no point in splitting it. So.
It's a truly 24-hour acting drug.
We have in pantoprazole we have an 80 mg OD dose.
And that's a dual dose PPA. Double dose PPA. That's not. It's not. You got dual dose release pattern in all PPAs. Now to Arun, H. pylori treatment.
That's what we have been recently discussed. No? There are various regimens for H. pylori, right? Mainly nowadays, clarithromycin resistance, amoxicillin resistance are being very common. So always we need to choose a triple drug therapy. It's very important. You are going to choose your PPIs or PCAPs. When you are going to choose your PCAPs, potassium competitive acid blocker, the duration should be minimum for 14 days of therapy you need to give. Along with whatever the treatment regimen you are going to choose, your amox, clarithrol, your amox, metro, what are the regimens you are going. Now even for cardiac therapy with your bismuth at a rate of up to 240 milligrams per day, and you are going to combine, so you can use a cardiac therapy also. There are also trials to prove that along with the 1-aprazone. So why we are choosing 1-aprazone? Because we need to improve the intragastric pH. Once we are going to improve the intragastric pH at high rate, so there will be the bacterial proliferation rate will definitely come down. That is why we need to choose 1-aprazone when compared to other molecules. That's been more trials to prove it, and for the short duration of therapy, we'll be having more beneficial effects for that.
Now, couple of questions also. This with antiplatelets, I think I covered that in my slides. Use of vonoprazole with aspirin. I showed this study. You know, they did a long dose aspirin study, was compared lansoprazole and aspirin and vonoprazole and aspirin was studied. In fact, if you look at the long term effects, it is vonoprazole had a significantly fewer side effects and fewer recurrence of peptic ulcer and fewer direct new instance of peptic ulcer due to long-term use of aspirin. One was found to be superior. I did quote the study, but I did not go into the details. It is already there. And the other thing is that, Kaushik, you should tell me, is there any strategy where you can combine it with prokinetics, or should it be combined with prokinetics? Is there any value, and what is going to be the future? Are we going to get 1% everywhere?
Maybe, sir, I feel the gastroparesis part, if the patient is having a gastroparesis with GERD, maybe a diabetic gastroparesis or some other gastroparesis, maybe a prokinetic with PCAPs may work.
See, the rationale behind the use of prokinetics have been disastrous, and everybody else who uses prokinetics, apart where you rationalize the use of prokinetics, the prokinetics are used too much by non-gastroenterological population because of they think that a PPI combined with a prokinetic has got a synergistic role. They do not understand, sometimes they do not take the value of how much the prokinetic, how much is the PPI is to be optimized. And it is easy just to make the patient complain, the combinations are used. I'm sure I certainly would not welcome a combination of a prokinetic with this thing. Whenever you need a prokinetic, it has to be used for its own merit, not because there is a combination available. I don't respect the combination, but it can be used only for compliance purposes. But never use a combination unless otherwise necessary.
That is the overusage. Domperidone 30 BD, like for example, any PPI with domperidone is usually OD. The most of the prescriptions comes with the BD, so that is also.
The maximum dose allowed for domperidone is 60 milligrams, but the ideal dose is only 30 milligrams. 60 is also allowed, but those high doses, people don't understand that the prokinetics do have a significant impact on the heart. It causes significant impact. People can have cardiac issues. So it is very, very dangerous. The domperidone, including, which is a very, very, very safe that domperidone do, on studies have clearly shown that there is some impact on the heart electrical activity.
But Arun recommends approximate can be co-administered.
No, they can be. There are papers to try in the field, but usually approachment mainly for the functional postpartum dyspeptic symptoms. So you can try along with that, but as a problem, we need more papers to document all those things, sir. Because since we are using vonoprazole only for the past 2 to 3 months in field, so we couldn't come to the conclusion we can have to use. But ideally, PPIs, vonoprazole should be given alone. And whenever you are going to use a prokinetic, mainly choose the patient where you are going to look for evidence of gastroparesis is there or not. And there are now so many advanced investigation protocols are there to look for gastroparetic states.
You should rationalize anything, sir. Just because when you want to use something, just because two are available together, buy one get one free, does not mean you have to take it. You have to rationalize. Does this patient require a prokinetic, or is there some pathogenesis behind? Like if this patient has got a large hiatus hernia, he's got a poor esophageal clearance, he's got a gastroparesis. In such conditions, additional, if those were to contribute to his symptoms, then an additional prokinetic, yes, is definitely warranted. But just because a combination is available, we have got one with D, so let's try this. No, the pharma industry has all made to look that any of these combinations is far superior to a single drug. They have not, it is irrational. I don't get a combination in UK, I don't get a combination in US, Australia, New Zealand, nowhere. Nowhere in the world. Our DGCA is, far lenient in allowing all these sorts of combinations. Anybody can go and this thing. They are like masala. Cook 1 and 2, make a masala and make a new name and then bring it out. But such combinations, if they are irrational, you can never get that combination outside the country. So you have to rationalize, you have to apply a strategy, you have to think how much important is a prokinetic in a particular drug or combination. You just can't, just because it is available with a combination, okay, this is available with the X is available with the D, so it should be more superior. No, not like that. It doesn't, it only will lead you to give you more side effects and trouble than truly beneficial.
So what about antacids and alliginates? Alliginates and antacids. Where do we stand there? Because we have come a long way. So they were the starting, and we use it with PPIs.
The alginates were not the starting. The antacids were the starting. Alginates came in between. Alginates are different. Antacids are different. Alginates.
That's why I'm saying antacids.
Sodium alginates, what is the role is, there's something called nocturnal acid breakthrough.
Yes.
And what happens is when you give, there's a buffer formation on top of it, so that the reflux is prevented. Definitely it helpful for nocturnal acid break.
And does it help when we use it sometimes with PPIs? So same way can use it with
it helps,
this
but,
molecule.
This molecule is specifically better compared to PPIs and nocturnal acid break.
So probably there's no
So
need.
probably there's no need of an alginate.
Alginates. Exactly. I know that antacids are different.
Or
than
sometimes
alginates.
when you use, without using PPA also, you can try alginates.
Yeah.
So to just relieve that nocturnal GERD,
Yeah.
that's one condition which is very disturbing. There are a lot of heartburn and disturbance in sleep. That time the sodium alginate really helps.
Thank you.
Around enteric infections with use of vonoprazan.
So, see, as of now, regarding septicemia and intensive care, we need to be very cautious with usage of PPIs because so many infections are being, even for many conditions. If the patient is immunocompromised, most of the time, so many infections to flare up with your PPI. But how far we are going to choose, and now we are going to identify whether the patient is going to succumb because of the PPI. That's very difficult most of the time. And regarding your PCAPs, the rate of infection protocol, I mean, when compared to your PPIs, is almost equal, but not that high with your PPI. For example, your Clostridium difficile infection, there are some papers to document. Even for candidiasis, there are some papers to document with your this one. And some rare gut infections like your salmonellosis may get worsened with your 100%. That's not been tried in various papers they have mentioned. But usually, based upon few things, if you're going to look into the adverse events and other things, for every molecule that we use this adverse events. For example, even with your PCAP, you may develop a material changes over a period of time. There are papers to document even that in Japanese study they have mentioned that. So, but how far it's going to recommend in your routine clinical practice and how are you going to implement that and how you're going to see in your routine practice it matters when you're going to choose this kind of patients.
The most important thing that I would like to add up is Clostridium difficile. Yes, it is partly increased with PPIs. It is all again collaborative data. The same with vonoprazan also exists. It is true. Enteric infection, if you call Clostridium difficile, is a little increased with PPI and with vonoprazan as well. There is no doubt about it because you are taking away the main protection, which is the acid. So you are likely to experience a little bit more